Good morning, everyone. Welcome to the RCI G- webinar, Alzheimer's 102, presented by Dr. Alfonso Martinez. Before we get started, let's cover a few conference details. If you have a question during the conference, you can type the question or use Raise the Hand feature. All questions will be answered at the end of the conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of the webinar. There will be 10 questions about the webinar and some personal information questions such as your name and email address that will enable me to send you your certificate. If you are not at your own computer, copy down the link that is posted on the last slide of this presentation. Use the link at your own computer to complete the post-test. Certificates will be sent out within 1 week to those who have successfully completed the training. Please complete this test by Wednesday, July 25th to receive your certificate. We are now ready to begin. I would like to welcome Dr. Alfonso Martinez.
Thank you, Elaine. And we had a couple of technical glitches this morning, so I'm thrilled to be on with you folks. This is a topic near and dear to my heart. I am a neuropsychologist in Peachtree City, Georgia, and I dedicate a significant part of my practice to evaluating folks with dementia and Alzheimer's. And so I'm very pleased to be here with you this morning. And this is my first webinar as a presenter, and so hopefully things will go well from a technical standpoint. And so let's go ahead and get started. And my goal is to leave time at the very end for questions. I don't know if there's a way for me to take questions as we go along. I'd be all right with that, but either way will be fine. Hopefully by the end of the seminar, of the webinar this morning, I'll be able to make the distinction for folks. A lot of folks have questions about what is the difference between dementia and Alzheimer's. And hopefully that will become clear to you as we go along this morning. So to begin with, I'd like to talk a little bit about the historical roots of dementia. The term dementia comes from the Latin word demens, which means without mind. References to dementia can be found far back, thousands of years in Roman medical texts from before Christ. It was in 1801 that French physician Philippe Pinel first used the term demence to describe a patient. So in a sense, this was the more modern root of the term dementia. And Pinel was the first to provide a good description of dementia. Incidentally, as I've read a little bit more about Pinel in preparing for this presentation, he also did a lot of good in French sanatoria in terms of bringing more civilized ways of treating the mentally ill. Some outdated terminology that I still hear people bring up in my office. Folks talk sometimes about arteriosclerosis, which involves hardening of the arteries. Some of these terms that I'm about to mention have been used interchangeably with dementia and with Alzheimer's in the past, but as medicine has progressed, I think that this is happening less and less. The term senile dementia, meaning dementia in later age, senility also has been used, a term called organic brain syndrome. And then kiddingly, I mentioned the term old-timers many times in Florida where I practiced before coming here to Georgia. People used to refer to old-timers instead of Alzheimer's, and I always found that interesting. But I really do not believe that it's been used by physicians very much. So what is dementia? Dementia suggests a decline in a person's memory and other cognitive functions. The decline has to be sufficiently severe to interfere with everyday living, or what we call activities of everyday living, a term that I'm sure most of you are familiar with. And there are different levels of activities of everyday living. At the higher level, we talk about instrumental activities of daily living. which are impaired earlier on in the course of dementia and Alzheimer's, and these are things like managing a checkbook, making and keeping appointments, taking care of your medications, and then as the disease progresses, then more basic activities of daily living, of course, are affected, as you know, and those involve things like dressing, toileting, feeding, and those kinds of things. There are multiple causes for dementia, and I'll talk about those in just a little while. There are two general courses. One can be static, where the dementia does not progress, and a good example of this would be a person who suffers a traumatic brain injury and or a stroke, and so we see an initial worsening, of course, of cognition, and then there should be some improvement over time, and then it plateaus and it remains unchanging or static. Here today I'm going to, of course, be talking about progressive dementia, things that tend to get worse over time. The term dementia implicates an abnormal brain change, so it's not a term that we would typically use to describe the normal memory changes that are associated with the aging process. And of course, like I say in the last bullet, it's not a normal part of aging. So if you can imagine this, dementia is a fairly broad category, and it encompasses many different diseases, and Alzheimer's is the most common type of dementia in individuals above the age of 65. So let me talk to you a little bit about the origins of Alzheimer's. Alois Alzheimer was a German psychiatrist and neuropathologist who practiced in the late 1800s and early 1900s. And in 1901, he described a patient, Auguste D., and this was the first description of a patient with early onset dementia. And nowadays we define early onset dementia as anyone who develops dementia before the age of 65. After his patient died, Alzheimer's did an examination of her brain that showed plaques and tangles, and now, about 100 or so years later, we well know that plaques and tangles are the typical changes that we see on examination of the brains of individuals who had Alzheimer's during life. And this is a description that Alzheimer's, these are some of his observations regarding his patient, Auguste D., and the translation is a little rough, but I'll go ahead and read over it as you follow along. As one of her first disease symptoms, a strong feeling of jealousy towards her husband. Very soon, she showed rapidly increasing memory impairments. She was disoriented, carrying objects to and fro in her flat, and hid them. Sometimes she felt that someone wanted to kill her and began to scream loudly. After 4 years of sickness, she died. And this is an actual picture of Auguste D. And the interesting thing about this is that we know Alzheimer's to generally be a disease of later life, usually affecting people above the age of 65, and I'll talk a little bit more about statistics here in just a minute. And ironically enough, his first description of a patient with what now we know to be Alzheimer's disease happened to have been a person who was in her 50s, and so it's sort of ironic that it turned out to be this way. But this was the beginnings. So some years after she died, they started to talk about this patient. Once Alzheimer's had examined her brain and had found these plaques and tangles that I made reference to, those were the origins of what we now know to be Alzheimer's disease. So these are different types of dementias, and really I probably should have been a little more specific here. These are dementia types that we see primarily in individuals above the age of 65. So if we were thinking of dementia in younger adults, we would be thinking more of traumatic brain injuries, potentially strokes, brain tumors, different infections, AIDS, and diseases like that, where here we're talking about dementias that affect individuals primarily above the age of 65. And at the top of the list, of course, is Alzheimer's dementia. Not far behind is dementia with Lewy bodies, which I probably won't talk too much about today, but deserves a presentation unto itself. There's something called frontotemporal dementia, which mostly involves personality changes, and person becomes disinhibited and does things and says things that are inappropriate. Vascular dementia is what some people refer to as multi-infarct dementia, which is a type of dementia that first develops as a result of the collection of strokes in a person's brain. So vascular has to do with the vascular system of the body, or how blood gets around. So in this case, it's not enough blood getting to certain areas of the brain, and that causes small strokes over time. And as these strokes collect in the brain, they have the potential to cause dementia. There's alcoholic dementia, and then other types of dementias that are somewhat less common. Well, Parkinson's disease dementia is fairly common. So people who have diagnosed Parkinson's disease are at increased risk of developing dementia in relation to other folks who aren't diagnosed with this disease. In fact, numbers are about a third of all patients with Parkinson's at some point in time will develop some degree of dementia. There's Creutzfeldt-Jakob disease, which is also known as mad cow disease. There's amyotrophic lateral sclerosis, or ALS, also known as Lou Gehrig's disease. And there's normal pressure hydrocephalus, which many of you may be familiar with, and that's a condition where the fluid that bathes our brain, what we call the cerebrospinal fluid, is not circulating normally, and too much fluid collects on the brain, and it causes all kinds of problems, including incontinence, gait disturbance, and also some degree of memory loss. So these other dementias that I mentioned are not. This is not an exhaustive list. So there are many other conditions that affect the mind, but these are some of the most common ones. And this is a pie chart of the distribution of dementias, and this is, again, primarily when we're talking about older adults. And as you can see, Alzheimer's has the disproportionate largest piece of the pie or pizza, however you decide to look at this. And so about 60%, and there are estimates that say maybe as much as 75% of dementia in individuals above the age of 65 is Alzheimer's. You'll see Lewy body is second behind Alzheimer's in terms of how frequently it occurs. And then vascular dementia, frontotemporal dementia, and then other types of dementias. So again, today I will primarily talk about Alzheimer's, although at the end I'm glad to take questions about Lewy body, because some of you may have heard of this and have questions about it. So here are a few kind of sobering statistics regarding Alzheimer's disease. At the present time, it's thought that it affects about 5.3 million individuals in the United States. That number is projected to increase to anywhere between 11 to 16 million by the year 2050. So these are just staggering statistics in terms of what it will mean for our societies in terms of cost. And about 120,000 Georgians are estimated to be affected by this disease. It affects 1 in 8 individuals who are above the age of 65. And starting at age 65, at age 65, your risk of developing Alzheimer's is anywhere between 1 and 5%. But every 5 years after age 65, your chances double. So essentially, if you are 70, your chances are twice what they were at age 65 of developing Alzheimer's. If you're 75, your chances are twice as likely as a 70-year-old to develop Alzheimer's. And so as you might imagine, with our aging population, that's why these projections are that we'll have maybe 2 or 3 times as many individuals with Alzheimer's in 2050 as we do now. Half of those individuals above the age of 85 are estimated to suffer from Alzheimer's. Women are more often affected than men. And the life expectancy of someone after they've been diagnosed with Alzheimer's is anywhere between 8 to 15 years. And this degree of variability in life expectancy is not only a function of the fact that the disease moves a little differently in different individuals. So sometimes the course is very rapid, and in other individuals it's a very slowly progressive course. But also the range here is because people are diagnosed at different points in time in the disease. And so my push is to try to evaluate people early on and provide the diagnosis early on. But there's a lot of resistance on the part of families and certainly on the parts of patients to come in to receive this kind of a diagnosis or to be examined for this kind of diagnosis. So here are some cost estimates regarding dementia care. It's estimated that we spend about $200 billion per year in the United States for dementia care. It is 3 times more costly to provide treatment to an individual with Alzheimer's as it is to provide the same care to a non-demented older adult. If you can take that in, so it's probably already costly if you're talking about a 75-year-old who may suffer from high blood pressure and diabetes and cholesterol problems. The cost for that individual already is probably quite high, but if that patient has Alzheimer's, it's 3 times more costly. The typical monthly cost for an Alzheimer's unit in the area that I'm in, which is in Peachtree City, is anywhere between $3,500 and $5,000 per month. So this is extremely costly, and I don't really know what all are the options for people who can't pay for this kind of care. My family has been affected by this. And my father-in-law right now is in an institution, and it's extremely expensive for my mother-in-law to be covering those costs. This is something that families cannot possibly plan for. And as many of you know, Medicare does not cover the cost of institutional or in-home care for Alzheimer's. And quite honestly, if they did, it would bankrupt the system. So some of the changes that we see in the brains of individuals with Alzheimer's, I've already mentioned them. There are what we call amyloid plaques. And these plaques, if you can imagine that the brain is made up of many, many neurons or nerve cells, literally it's in the billions of nerve cells or neurons that constitute the brain. And these plaques collect in between the neurons. So they're not actually in the neurons, but they collect around the neurons, and over time it causes what we call neuronal death. There's also something called neurofibrillary tangles, and this actually is something that's occurring within the neuron or nerve cell. So it's a kind of a two-pronged process of the brain being attacked by these plaques and tangles, and different researchers believe that the biggest cause of Alzheimer's is really the plaques, and the tangles are secondary, and then others believe that the tangles are more important than the plaques, and so that's been an ongoing issue for researchers, and we really don't know the answer to that question. In the Alzheimer's brain, there is a disproportionate of atrophy to a specific area called the hippocampus, which is the memory center of the brain. And sometimes in brain scans, whether they're CT scans or MRIs, a neuroradiologist may be able to look at that scan and specifically look at the hippocampus and determine whether there has been some shrinkage of that specific area. Now, I should be clear, I don't recall if I talk about this in a later slide. An MRI brain scan is a very important part of the examination for Alzheimer's, but it is only a small part of it. And so what I'm referring to here in terms of looking for changes in that hippocampus of the brain, it's a nice marker for us to look at, but it does not give us the diagnosis. So that if we have a patient who's very forgetful and on exam, all indications are of Alzheimer's, and we see this disproportionate shrinkage or atrophy of the hippocampus, then we can be more secure in our diagnosis. But this is not the way that we diagnose the disease. I'll talk about that. I'll talk about the diagnosis in just a minute here. And then there's generalized atrophy of the brain cortex, or the covering of the brain, which is very nicely shown in this picture that you see up above. If I could see a show of hands, I would ask which is the Alzheimer's brain, but most of you would figure out that it was the one on the left, and then the right is a normal brain. Some of the risks for Alzheimer's, at the top of the list is age. Then not too far behind is family history. If your mother suffered from Alzheimer's, that puts you at greater risk than if your father was the one to suffer from Alzheimer's. And if both of them did, you're in trouble. No, and I should leave kidding aside. It does impart greater risk if one or both parents have been affected, but it's not a perfect correlation, of course. And so there are many people who have parents who had Alzheimer's who themselves never develop Alzheimer's, and vice versa. There's many people who have no family history who themselves develop the disease. Down's syndrome almost always ends in Alzheimer's at some point in time. If the individual with Down syndrome is, you might say, lucky enough to live long enough, inevitably they will develop Alzheimer's. Head injuries, strokes, anything that has affected the brain, any brain accident it predisposes a person to later on develop Alzheimer's. And it doesn't have to be within a year or two of the head injury, but it could be many years later. There was a very interesting study done with veterans, and the nice thing about the veterans is that they had very detailed records of any head injuries that they had during their service. And so they looked at those veterans that in their late teens and early 20s had serious head injuries, and those folks were more likely to develop Alzheimer's down the line than veterans who had never suffered head injuries while they were in the service.
Dr. Martinez, we have a hand raised.
Yes.
You want to go ahead and take a question?
Sure. Yeah, let's try it.
And Keisha, we know who you are, but we don't know which phone number is you to unmute you. So if you can type that in real quick, we'll unmute you.
Yeah, and my preference would be to hear Keisha's voice, but I see her question here.
Okay, all right.
So if it's going to be complicated to get her to unmute her, I'm glad to try to address the question without hearing her. So Keisha asks, what about people diagnosed with epilepsy? That's a great question. People with epilepsy have potential cognitive problems to contend with themselves, not necessarily Alzheimer's. So, one thing is, where is the epilepsy coming from? Was there something in the person's brain development, or was there some trauma via a head injury at some point in time that then predisposes them to epilepsy that also may predispose them to have some degree of cognitive impairment? The other thing is that if epilepsy is not well controlled, it's thought that these abnormal discharges in the brain of electrical energy that defines epilepsy, if you have enough of those discharges, it can cause memory problems on its own. And then yet to complicate the matter even a little bit more, medications for epilepsy also have the potential to create some degree of cognitive impairment. So right off, I don't know the statistics as to whether people with epilepsy develop Alzheimer's at a greater rate. But I can tell you that epilepsy has its own challenges for the reasons that I just mentioned. So that's a very good question. I hope I addressed your question, Keisha. Depression in later life also is sometimes a risk for Alzheimer's. So this is a person who earlier in life, in their 20s, 30s, 40s, 50s, never suffered from depression. And if they develop depression for the first time in their 60s, many times it's a prelude to a dementia that's coming up, or Alzheimer's. Now, that's not always the case, but I can tell you that if you're working with someone who never earlier in life suffered from depression, begin to have depression in their 60s, you need to keep a closer eye on them. And then finally, this term mild cognitive impairment. Again, if I had a live audience in front of me, I would ask how many of you have heard of MCI. I think a lot of people more and more have heard of this term. Mild cognitive impairment is a term that we use to describe individuals who have trouble with memory, but other areas of cognition, such as language, what we call executive functions, visual spatial abilities, all those other areas are intact and unaffected, and that's what defines mild cognitive impairment. So again, it's what we call a circumscribed memory deficit with other areas of cognition being intact. And one way of distinguishing people with this MCI and people with Alzheimer's is that we know individuals with Alzheimer's may show primarily a memory impairment early on, but inevitably over time things get to where not only memory is affected, but other areas of cognition as well. So I thought it would be worth sharing with you the Alzheimer's Association 10 warning signs for Alzheimer's. And I'm probably not going to comment too much on these unless there are questions. So number one is memory loss, that it disrupts daily life, and I think that's a really good one. Challenges in planning or solving problems, difficulty completing familiar tasks, confusion with time or place, trouble understanding visual images and spatial relations, new problems with words in speaking or writing, misplacing things and losing ability to retrace steps, decreased or poor judgment, withdrawal from work or social activities, and changes in mood or personality. Now, part of the reason why I wanted to show you these 10 warning signs is because I really then want to show you my 3 warning signs. My thinking is, with people's span of attention being as short as it is nowadays, let's come up with 3 things that are warning signs rather than 10. And so these are my famous Martinez 3 signs of Alzheimer's. And a bit repetitive, I agree. Number 1 is memory decline. Number 2, memory decline. And number 3, memory decline. And I'm hoping I'm getting some smirks and smiles on the other end. And this is what I really want you to take away from this presentation. Memory is where it's at in terms of trying to catch this disease early on. You can look for some of the other signs, and many of them I think are very reasonable, and in fact they are things that we know are affected in Alzheimer's, and I'm referring to the 10 warning signs that I just showed you. But if you really want to catch the disease early, either in yourself or a loved one or an older adult that you're working with, really it's memory where it's at, and so I'm going to spend a bit of time here telling you what I see as being memory problems. First of all, the memory changes in Alzheimer's, particularly early on, it's not an all or nothing. So just yesterday I was seeing a patient in my office, and we were talking about memory and this gentleman's forgetfulness, and a family member that came along jumped in and said, well, he doesn't forget everything. And, my answer is, well, of course not. These are things that at the very beginning, they just show up as being a little bit of a problem, but of course, as time progresses, they become more obvious. So again, it's not an all or nothing. It's not, if you think about it, of course, that makes sense. It's not that a person is forgetting everything, but it's that they're forgetting more things than they used to. So in the early phases, it's just spotty memory. There are the patient with early Alzheimer's will be able to remember many things, but they will be forgetting more than is normal for them. Some days their memory may seem very normal. Inevitably, because of the course of the disease being a progressive course, the memory problems will become more obvious. Short-term memory is affected early on, and short-term memory refers to recall of things that occurred earlier today, yesterday, the day before, last week, the last few weeks. And then when we're talking about long-term memory, those are things that occurred months or years ago. And curiously, in Alzheimer's, long-term memory is preserved early on in the course, where short-term memory is really what's affected. Now, as the disease progresses, we know that even long-term memory begins to be affected. So, if you know somebody or are working with somebody where they can provide lots of detailed information about when they were in the service, or when they were children, or when they were in high school or college, or they can talk quite well about things that occurred many years ago, do not make the mistake to think that that person can't possibly have Alzheimer's. If they're struggling to remember things from the recent past, then Alzheimer's still is a possibility. So what are the specific signs to look to figure out if someone is having trouble with memory? At the top of my list is repetitiveness. I can tell you that repetitiveness is never a normal part of the aging process. If someone is asking the same question repeatedly, and that doesn't necessarily have to be in a short span of time. It can be within hours or from one day to the next. If they're asking the same question again, chances are that they're forgetful and in an abnormal fashion. When people tell the same story, again, not remembering that they've already told it, again, a likely sign of abnormal memory changes. And to me, it seems somewhat obvious that repetitiveness would be a serious sign of memory decline, but I'm always surprised at, talking with family members coming into my office where they present repetitiveness as if it's somewhat benign and really doesn't mean anything. Now, every so often you'll have the very proud veteran or very proud chairman of the board or someone who loves to tell the same story over again, but not so much because they've forgotten that they already told it. Forgetting conversations also may be related to dementia or Alzheimer's. It could involve forgetting the details of conversations. It may involve forgetting having had a conversation altogether, or if the individual's recollection of the conversation is quite different, then potentially that is a sign of memory loss. Other signs of memory changes include forgetting recent events and items. This could be forgetting to have attended an event in the recent past, watching a movie or a TV program, inability to recall recent items in the news, forgetting things that you've read in books. So oftentimes as part of my interview, I will ask patients, I'll ask them if they are ones to keep up with what's happening in the news and in politics, and if so, I'll try to engage them and ask them what's been going on with the elections, what's been going on in different countries, and that's not a fail-safe way of examining someone's memory, but it starts to give me a sense of what's going on. Of course, that's a little complicated. Many older adults begin to disengage a little bit about what's happening in the world, and they're more interested in what's happening closer to home. So again, just because a person doesn't know about big news items, it doesn't mean that they're forgetful. It may be that they're just not keeping up with those things any longer. Another sign of a memory change may involve forgetting upcoming dates and appointments. In the earlier phases of Alzheimer's, people are able to make up for this forgetfulness by coming to rely more on a calendar or on notes. And so some people will say, oh, well, I never forget appointments, but on further questioning, really it's that they've come to rely quite a bit on keeping a calendar. Tendency to misplace things. also is a sign of memory loss, of course. Forgetting where things are usually stored. This is kind of an interesting one, and I remember seeing this fairly early on in the course of my father-in-law's Alzheimer's. He always enjoyed having a drink with us in the evenings before dinner, and so one of his usual rituals was to get a hold of the corkscrew and get a bottle of wine and uncork it. And I remember many years ago him struggling, looking through several drawers in the kitchen before he figured out where the corkscrew was. Leaving drawers open or lights turned on, and then trouble remembering people's names. So let's talk a little bit about what's the examination involved to get to the bottom of whether someone has dementia or Alzheimer's. And I've already made reference to some of these things. There's a neurological exam, and this exam may be actually done by a neurologist, or oftentimes it's done by a primary care doctor, either a family physician or an internal medicine doctor. You know, I would say that if the individual is showing just memory loss and isn't showing other neurologic signs, and there I would include things like problems with their walking or their gait, tremor, headaches, double vision. If those things are also occurring in addition to the memory loss, then in all likelihood that person will also need to see a neurologist in addition to seeing their primary care doctor. But if it is just memory loss and it doesn't seem complicated by these other neurologic type symptoms, then maybe just the primary care doctor is sufficient. There is blood work that the patient needs to have done to make sure that there's not some sort of vitamin deficiency that's causing the memory loss. It's fairly standard for the individual to undergo a CAT or MRI brain scan. The CAT scan is a little more cost-effective, but shows a little less detail, while the MRI scan is a little more expensive and shows greater detail in the brain. There are specialized procedures that can be used in the examination for dementia, but these are as necessary, and these might include a brainwave test or EEG, a lumbar puncture, or a PET scan. And there's a lot of promise in PET scans. This may be the wave of the future. What a PET scan does that's a little bit different than a CT or MRI is that it shows the metabolism of the brain. So it shows which areas are more active and which areas are less active. But it's not yet used as a typical part of the examination. And then there's the part that I do, which is the neuropsychological evaluation. And, some things that are involved is a detailed history of the cognitive changes. There's direct testing of a person's cognitive functioning. So this is, what I find to be particularly useful about my exam is that sometimes you'll have family members who disagree as to whether a patient is having problems and or they disagree as to the extent of those problems. And so the neuropsychological testing really helps to make that distinction, and like that we're not at odds because one family member says one thing and another family member says something different. There's also a consideration of emotional factors, as I'll talk about in a slide or two from now. There are emotional factors that can either cause memory problems or can worsen them. A full examination for dementia or Alzheimer's, that includes the type of medical or physical exam that I talked about, together with the neuropsychological evaluation, has been found to be anywhere between 80 to 90% accurate in diagnosing Alzheimer's. So these are what we call pathological studies, where they have followed individuals who were diagnosed with Alzheimer's during life, and then these individuals donate their brains, and then the brains are looked at under the microscope to see if they show the typical plaques and tangles of Alzheimer's. And so about 80 to 90% of the time when we've made the Alzheimer's diagnosis during life, we are correct once we take a look at the brain underneath the microscope. So these are some important things to rule out, which I've sort of made mention of. an abnormal thyroid, so having too much or too little can be a problem. There are metabolic disorders. These include vitamin deficiencies or an electrolyte imbalance. And so these are the parts that need to be checked out by the medical or neurological exam. There could be a sensory decline, so a person may have hearing loss, and so they may seem forgetful, but in fact, if the information is not getting in there to begin with, then they're certainly not going to be able to remember it. There can be medication effects. I mentioned epilepsy medications earlier, but there's all different types of medications, pain medications, medications for fibromyalgia, many of them which can cause memory problems as a side effect. And then I made mention of emotional issues. Depression, if it's severe enough, can present very much like dementia, so that the person may be very forgetful and disengaged, and they may seem disoriented, but it may be more of an emotional withdrawal rather than related to dementia per se. There can be anxiety, stress, and it doesn't have to be one or the other, I should mention. There's many individuals who have both Alzheimer's and depression, so in some cases it's not just that the person's being affected by one condition, but rather by more than one condition. Then alcohol abuse or overuse, of course, can relate to dementia or can look like dementia. So these are what I see as some of the barriers to early diagnosis. There's a fancy term, anosognosia, and that has to do with the patient being unaware of their memory problems. So this is very common for those of you who have had a lot of experience with Alzheimer's and with patients who have dementia. Oftentimes, they're just plain unaware that they have memory problems, and in other cases, if they have some awareness of it, they tend to underestimate the extent of their problems. And this is a very, very common phenomenon. The primary care physician is not concerned after he or she has done mental status testing. So sometimes a brief exam may be done in the primary care doctor's office, and because the patient can name the president, the vice president, and can think of what they had for breakfast earlier that day, then in a sense they're off the hook, and an appropriate referral is never made for further workup. People are afraid of the unknown, and so oftentimes they put off coming to see someone like me because honestly they don't want to know what's going on. There's this sense that there's not a cure. There's a sense of hopelessness. Aunt Betty is a reference to many people, I believe, have seen someone in their family, and I call that someone in their family Aunt Betty, who developed a dementia or Alzheimer's. And so in their mind, you know, the way that Aunt Betty went, that's a normal part of aging. And so they tend to normalize the aging process as one that involves a lot of memory loss, where that's not at all true. And so people normalize what they're seeing in their parent or other loved one, and they think, well, geez, you know, mom is 78, she deserves to have a little bit of memory loss, and so they let things go rather than addressing them. And then sometimes there are distant family members, and here I mean physically distant. So, it might be a parent here in Georgia, but the kids are up in Ohio or wherever, and, they only talk with mom once a week or a couple of times a week. They mostly talk about the weather. They keep conversations kind of light. And so during that time, mom or dad can be developing pretty significant dementia, and it wouldn't necessarily be apparent to family members. All right. So to begin to bring it all together in conclusion, there are many types of dementias. So one of the take-home messages here should be that dementia is the broader category, and Alzheimer's happens to be the most common type of dementia. Memory decline is the most important change in early Alzheimer's. Early-stage Alzheimer's can be subtle, so that the individual may look pretty normal on the surface. Alzheimer's is not an obvious disease in its earliest stages unless you're that person's spouse and you see how forgetful they are from one day to the next. But again, a short, brief interaction will not always give it away, particularly if it's in the early stages. And in fact, here in my office, after 14 or 15 years of doing this type of work, I will talk with a patient for a full hour, get a full interview from them, and in the end, I'm still left scratching my head a little bit as to whether or not they've got a problem. And therein is where the cognitive testing is really helpful, because then that does show off whether there are memory problems. And we can diagnose Alzheimer's with a high degree of accuracy. And this is a preview. Some of you may already be aware that I'm going to be doing a follow-up presentation. I'm almost certain that the date is September 20th, and I believe it's at the same time. And there I'll continue to review Alzheimer's and focus more on treatment for Alzheimer's. I'll be talking about Aricept and what we call cholinesterase inhibitors, Namenda. There's other things that are coming on that are very exciting. I'll talk a little bit about treating behavioral problems in Alzheimer's, and also share with you some caregiving philosophies. So please look for that. And then, Elaine, I'm going to go on to the last slide here.
Yes, that would be great. And at this time, I would like to thank you, Dr. Martinez. We really do appreciate it. And I am going.
The conference has been unmuted.
I am going to unmute everyone, and if you do have any questions at this time, please raise your hand, and I will call on you. That will keep us all from asking the questions at the same time. Dr. Martinez, there are some questions down in the chat. Would you like to address, please?
Yeah, I'm going to go ahead and take Sylvia's question. She says, please briefly detail major distinguishing characteristics of Lewy body dementias. Great question, and this is a topic unto its own. Lewy body, the major things that we're looking for involve Parkinsonism, so that the person becomes stiff and tremulous. We're looking for fluctuations, where sometimes they're more clear-minded and other times more confused. And we're looking for hallucinations, oftentimes visual hallucinations. So these are people who begin to see things that are not there, which is also part of Alzheimer's, but that occurs in more advanced Alzheimer's, where in Lewy body it occurs in the earlier stages. So very important type of dementia. Folks, be aware that your phones are now unmuted. So if you could please try to keep it down on the other end. Thank you. What are the features of Pick's dementia? There is something called Pick's disease, which falls under the category of frontotemporal dementia. And what we're looking for there are behavioral changes and personality changes. So people with Pick's disease will say things that are inappropriate in public. They may make off-color jokes.
The conference has been muted.
Mute him.
Changes, although memory also is affected to a certain extent. Let's see. I'm going to try to address Gail's question here. What research has been done regarding the incidence of Alzheimer's disease following head injury in later life? Several people have shared that their mother loved one appeared quite sharp mentally, but after a head injury, noticeable decline occurred. Yeah, I mean, Gail, no doubt after a head injury, depending on the severity of the head injury, okay? If it's a mild head injury, meaning that the patient loses consciousness for up to half an hour, then they shouldn't have long-standing problems with memory. So again, mild head injuries, there might be problems in the days or weeks following the head injury, but they tend to resolve completely. If we're talking about moderate to severe head injuries, and now we're talking about loss of consciousness of 30 minutes or more, then we may potentially have situations where there is a decline in memory that is permanent. And that's not Alzheimer's. But like I mentioned before, we also know that people with head injuries are predisposed to later developing Alzheimer's down the line. So, and then there's a possibility that there's both. I see a number of patients in my practice that come in and they're referred because they've had a head injury, but come to find out they had been experiencing memory loss from well before that, and so it could be a combination of Alzheimer's and a head injury. So it doesn't necessarily have to be one or the other, but that's a very good question. I'm glad to take any other questions. I guess everyone's been muted, and I appreciate that. But if you want to type in any questions, or we can do I don't know, Elaine, if you can do
well, Dr. Martinez, there was a question in front of Gail's from Cindy.
Oh, no, I addressed that. That was on PICS dementia. So I've already talked to Cindy Krangle.
Okay, all right. Well, we will try to unmute again, and perhaps the noise will stay down.
Okay.
We have several questions typed in, so let's do it.
Yeah. Oh, it sounds like people are having a good time.
Yeah. Is alcoholic dementia just found in alcoholics?
Yeah. Thank you. I'm seeing those. Yes, and alcohol in large amounts is not good for the brain. I mean, there's just no question about it. I hope in the next webinar to talk a little bit more about how to decrease risk of Alzheimer's. And we know that one way to do that is by drinking in moderation, and that's defined by a drink and at most 2 drinks per night. Now, if I have a patient who has struggled with addiction and with alcoholism, of course I would never suggest to them that they get back to drinking. But if it's a person who's never had trouble with alcoholism and they abstain from drinking, I will say to them, hey, guess what? We know through research that if you have 1 or 2 drinks per night, that it can actually help your brain and your circulation. And so there is a positive side to use of alcohol, but of course in moderation. But yes, if we're talking about alcoholic dementia, that's specific to well, it is specific to alcoholics. It has to have been a chronic problem for many years. The brain is really pretty resilient, meaning that I'm always surprised. There are some people who I see in my practice who earlier in life were heavy drinkers, and they're apparently no worse for it. I don't recommend drinking heavily, but the brain actually bounces back pretty well in most cases, except of course if they cross a certain threshold and then they develop this alcoholic dementia. Should all folks 65 and older be screened, and what are screening recommendations? Great question. I believe that Medicare has implemented an initiative so that there is more cognitive screening, and it becomes more routine in individuals 65 and older. In a typical medical office setting, something like a mini mental status exam would be good. I also encourage people to ask a few questions, of patients, address, phone number, tell me about your grandchildren, how many do you have? Those are questions that you can ask and won't necessarily put the person off, won't make them feel like they're being examined. But if a person struggles with those kinds of questions, we very potentially have a problem. Having said that, that will miss a lot of people. So, the lighter the screening that you do, the more likely you're going to miss somebody who may have the beginnings of a problem. But yes, I'm all for screening. I think it's a great idea. So yes, I'm all for it. Gloria, please explain fixed dementia again. Gloria, you're going to have to. I'm not sure what you're referring to there. If you want to retype, I'm trying. Oh, I don't know if you're referring to FTD, maybe frontotemporal dementia. If you are, it has to do. Someone asked about something called PICS disease, which is similar, and it has to do with a dementia that initially affects the frontal lobes of the brain, and therefore it affects personality and social judgment and those kinds of things. But I'm not sure if I'm addressing your question. There's a lull right now. I'm glad to take any other questions. We still have, according to what I'm looking at, 5 to 6 minutes. And will a lack of B12 cause dementia? Potentially. There is a threshold which you have to cross. Let me say this. If you're eating a normal diet, if you're receiving regular medical follow-up, the chances that you're going to have a vitamin deficiency that is enough to cause dementia is pretty low. It's possible, and if you know that you have a B12 deficiency and memory loss, then the ideal thing would be, of course, to address the B12 deficiency and then see if that fixes memory. So yes, the answer to your question, B12 can cause memory loss, but the answer is no, it cannot cause dementia. Dementia suggests that there's a change in the brain, a more permanent change in the brain, so B12 deficiency won't cause that. And then Mary asks, could adults with various head brain sizes be at more risk for Alzheimer's? That's a great question. There has been some research that has suggested that individuals with smaller head circumference and presumably smaller brains are at increased risk. But, I haven't seen anything about that in a long time. Short, small people will, of course, disagree with this. But, just as a kind of a funny aside, a number of years ago I attended a conference on Alzheimer's, and with me was a good friend who is a pathologist, and he's a Hungarian guy. The guy is, just very broad-shouldered, has a huge head, and this topic of head size came up in the discussion, and everyone sitting at the table turned and looked at my friend Laszlo because his head stood out as being so large. So anyway, let's see. Next question. People who have severe migraine headaches cause Alzheimer's? No, migraine headaches can be a risk like epilepsy, like I talked about earlier. There may be some degree of cognitive impairment that comes with migraines. And certainly while someone is in the middle of having a bad headache or an actual migraine, of course their ability to think will be terribly impaired. And it is possible that if the migraines recur, that they may be causing some brain changes that could cause some degree of memory loss, but I don't know that it would cause Alzheimer's per se. So the answer is yes and no on that one. Let's see, Chairperson, will the slides be available? I do believe that the slides are available after the webinar.
The slides and the audio portion, so the entire webinar will be able to be viewed at a later date.
Okay. Folks, there's still, if Elaine says so, I think we've still got a little bit of time for questions here.
We still have 3 minutes. Does anybody have anything else they would like to ask? In the meantime, remember on the last slide, if you are not sitting at your computer, there is a link there to the SurveyMonkey where you can take your post-test later.
This is Laura at the RCI, and I just want to say, if you have questions that you think of the second we go off the air, go ahead and type them in, and we'll get that on our end, and then we can compile those and send them to Dr. Martinez to get answers for you.
Sure, I'm fine with that, yeah.
Dr. Martinez, we do thank you today, and we look forward to hearing from you again on September the 20th. Again, last chance, everyone. Oh, here we go.
Someone jumped in here last minute. Any recommendations to prevent Alzheimer's? And I think that this is something that I'll go into for the next presentation. But yes, to give you a little bit more of a preview, there's no question that the more active that you remain into your 50s and 60s, the better that you will fare over time, and the more that you will decrease your risk for Alzheimer's. There are good studies following people up starting in their early 60s, and they follow them up over the course of 10 years, and they find that those people who were more active are at decreased risk of developing Alzheimer's, and those that were the least active are at increased risk. So there's something about staying active mentally and physically that really decreases your chances of developing this disease. So, and I would develop those habits not starting in your late 50s. I would develop them now and carry them into the later years. Boy, that sounds pretty dismal for those of you who are 50s and 60s out there when I say later years, but I hope you understand that. I mean, the earlier that you can establish these habits of keeping a busy mind, a busy body, and remaining socially active, the better off you will be in the long run. There's very little question about that.
Okay, well, again, we thank you, Dr. Martinez, and that will conclude our webinar for Alzheimer's 102.
Thank you.
Thank you. Please stand by.